Pulpitis is inflammation of dental pulp, and it's usually caused by bacterial infections. The dental pulp is the soft inner section of the tooth that houses the nerves and blood vessels that nourish the tooth. If the pulp gets inflamed, these nerves get activated, really intensively. Pulpitis usually starts with either an injury to the tooth, such as a fracture, or commonly from tooth decay, which is when there's erosion of the overlying enamel and dentin layers, opening up a direct route to the pulp. Bacteria can then access the dental pulp and generate an infection. The most common bacteria include the mutans group Streptococci, such as Streptococcus mutans and Streptococcus sobrinus. The bacterial infection typically leads to an inflammatory response from the immune system. The inflammation causes tissue swelling, but because the dental pulp is encased in a tough layer of dentin, there's very little room for tissue to expand. That means that the tissues get squeezed and there's a lot of pressure on the nerves. Clinically, pulpitis can be divided into two types: reversible and irreversible. In reversible pulpitis, healthy pulp reacts to the presence of an irritant, for example, a deep carious lesion that isn't actually within the dental pulp. Now, irreversible pulpitis is much more serious because the pulp is actually damaged. For example, there may be a bacterial infection within the dental pulp. Usually, when there's an active infection within such an enclosed space, it is virtually impossible for the dental pulp to heal. Over time, the pulp undergoes necrosis, creating a dead tooth, and eventually, the bacterial infection can spread to surrounding tissues and bone. In reversible pulpitis, there's typically transient pain and sensitivity to things like cold, heat, or even sweetness in drinks and food. In irreversible pulpitis, there can be severe pain, and sometimes that pain can be hard to localize to the exact tooth that's affected. In reversible pulpitis, it's important to promptly remove the decay and then place a restoration to help stop the process, and allow the dental pulp to return to a healthy state. It's also important to seal the restored tooth, so that it doesn't get reinfected. In irreversible pulpitis, there are two main approaches for treatment. First, there's endodontic treatment, which involves removing the diseased pulp and filling it up with a filler material like a special cement. In this approach, although the tooth is dead, it can continue serving its mechanical function of chewing. The second approach is extraction of the affected tooth. Alright, as a quick recap. Pulpitis is the inflammation of dental pulp that's most often caused by a bacterial infection. Reversible pulpitis is easily cured, whereas irreversible pulpitis leads to a dead tooth, which can be kept in place to help with mechanical chewing, or it can be extracted completely.
Hyperplastic pulpitis, or otherwise more commonly known as the pulp polyp, is a type of irreversible pulpitis that originates from a chronically inflamed pulp. A pulp that has been in inflammation for a very long time. Hyperplastic pulpitis is usually found in teeth of young individuals, especially those young children whose teeth have been carious for a very long time. So as we have studied in our previous lectures, a tooth with a carious lesion first goes from reversible pulpitis and then to irreversible pulpitis if the cause is not removed in time, after which the eventual outcome of pulp will be pulpal necrosis. Since the pulp polyp is a type of irreversible pulpitis, the signs and symptoms are also similar to the irreversible pulpitis. Pulp polyp is usually asymptomatic, or it can also have signs and symptoms. Symptoms include spontaneous lingering pain just like those of irreversible pulpitis. There is, however, a special appearance associated with the pulp polyp. There is a large cauliflower-like outgrowth of connective tissue into the caries that has already resulted in large occlusal exposure. This outgrowth is essentially coming out from the pulp from the area that has already been exposed to the oral environment, which looks like a polyp and hence the name pulp polyp. This outgrowth is a classical sign which almost confirms the diagnosis of the pulp polyp. Treatment for pulp polyp requires removal of the diseased pulp. This may involve either performing root canal treatment or, in worst cases, performing extraction of the tooth in order to relieve the patient from their painful experience.
What do we mean by degeneration? We have heard this term most often in relation to old age, isn't it? Well, in this case too, pulp degeneration is commonly observed in older patients, but that does not mean it doesn't affect younger people. In older people, causes don't necessarily have to be related to infection or caries, whereas in younger people, it can be due to the mild but persistent irritation of the pulp. In the early stages, it is asymptomatic, that is, the tooth doesn't show discoloration and the pulp may react normally to the neural sensibility tests. So, how do we recognize pulp degeneration? Let's dive deeper to answer this question. The three types of pulp degeneration can be seen as three siblings: calcific, atrophic, and fibrous. Calcific is the extrovert because its clinical findings are clearly observed radiographically. On the other hand, atrophic is considered to be an introvert that doesn't publicly flaunt its clinical findings. And finally, the fibrous type is more of an ambivert that may or may not show its true colors. Let's discuss these siblings, beginning with the extroverted calcific degeneration. Calcific degeneration is seen when the pulpal tissue gets replaced by calcific material, like pulp stones or denticles. These stones are usually present in the pulp chamber and can block the canal orifices. Now, do you recall the oral histology lessons about the different kinds of pulp stones, namely free, attached, and embedded? Well, any of these can be present within the chamber, making it indistinguishable on a radiograph. A lot of times, pulp stones are discovered once we start with the access cavity preparation. Usually harmless, these can pose challenges in performing root canal treatment. Now, you must be wondering how we navigate our way into the canals in the presence of pulp stones. Well, for that, you need to keep a lookout for our future videos. Let's learn about another interesting concept of calcific metamorphosis. Do you remember seeing radiographs of patients with complete radio opacity in their root canals? Well, such radiographs imply that there has been a complete replacement of the pulpal tissue with calcific material. On clinical examination, these patients often have a history of trauma. Such calcific degeneration is called calcific metamorphosis. As we saw, it is a pulpal response to trauma, characterized by rapid deposition of hard tissue within the canal space. The tooth is mostly asymptomatic, except discoloration may be observed. In these cases, aesthetic management using full coverage crowns or laminates can be done. In cases where symptoms are observed radiographically or clinically, endodontic intervention is necessary.
Pop quiz.
Moving on to the next sibling, the introverted atrophic degeneration. As the name suggests, atrophy of the pulpal tissue is observed histopathologically. There is a reduction in stellate cells, leading to an increase in intercellular fluid. Clinically, it is commonly seen in older pulps, making it less sensitive. Since there is no clinical diagnosis for this condition, it is a purely histopathologic finding. Do you know that reticular atrophy, and atrophic degeneration are not the same? Reticular atrophy is an artifact produced by the delay of the fixative agent in reaching the pulp and is not a pathology like atrophic degeneration. It's finally time to discuss the ambivert sibling, fibrous degeneration. It is characterized by replacing the cellular elements with fibrous connective tissue. This pulp has a characteristic leathery appearance. However, it causes no distinguishing symptoms to aid in its clinical diagnosis. This fibrous nature is appreciated when the pulp is extirpated during root canal treatment. Lastly, let's discuss necrosis of the pulp, which literally means death. Necrosis of the pulp can be partial or total and can occur as a result of inflammation or trauma. An ischemic infarction leads to a dry gangrenous necrotic pulp. So when pulp decomposition occurs, the end products are those of protein decomposition, hydrogen, sulfide, ammonia, and other fatty substances. The unpleasant odor emanating from the root canal is due to the intermediate products during this necrosis. This probably takes you back to the pathology classes on liquefaction and coagulation. Moving on to the clinical presentation, let's discuss how we recognize a necrosed tooth. It is usually asymptomatic. However, the crown discoloration from dull and opaque to brownish can be the first indicator. Although you may not find anything specific to this condition on a radiograph, a diagnosis may occur incidentally. Here, partial necrosis can add to the confusion. Due to the presence of some vital nerve fibers, the teeth may respond to the neural sensibility tests, whereas a total necrosed tooth will not respond to thermal tests at all. In addition to this, some patients exhibit a history of pain for a few days, which then disappears. At other times, they may not experience pain at all while the pulp slowly gets necrosed. Therefore, a correlation of cold and electric tests, along with a history of pain in conjunction with a thorough clinical examination, should establish a correct diagnosis. The treatment of pulp necrosis is root canal treatment with a favorable prognosis if performed appropriately.